Good morning, everyone. I'm Peter Craftle from the University of Birmingham and from the FRESH Consortium. So, unfortunately, I am the Children, Young People and Families programme this morning. That's because Dougal unfortunately couldn't make it and Kaya is unwell. But I did want to acknowledge that they are part of the team. Dougal is the co-lead and Kaya the programme manager. And Hannah Fairbrother is our PPIE lead. So I'm not going to say too much about the programme. Following the structure of the other talks, I'm going to say just a little bit about our aims and some of the projects that we've commissioned and approved as part of the programme. And I'm delighted that David is going to talk a little about one of our approved projects and Erin about priorities from a policy perspective in terms of children, young people and families. So in terms of our vision, this really builds on the other presentations that we've heard. So I'm not going to repeat anything about inequalities, which are, again, at the very heart of our programme. I guess what's important to us is how those inequalities intersect with young age. And a key part of our programme is exploring children, young people and families from pregnancy through the early years, through learning spaces, including but not only schools, and importantly, Lorna, in terms of what you were saying about that kind of group of young people who are particularly prominent, the 20 to 24 age group, the transition to adulthood. So some of our projects look explicitly at older young people. So we also have a number of strands. You will hear a little more about the cross-programme strand in terms of improving intelligence for children, young people and families in a moment. And you can see the other three there. And these also articulate nicely with the other programmes, including inclusive and sustainable environments, a healthy start to life and learning environments. Now, you can read a little more about those three strands in the programme. What I did want to do is just to give you a flavour of the projects that either have been improved or we hope will be approved by exec shortly. So within the first, around inclusive and sustainable environments, as you can see, the projects range from exploring mental health outcomes amongst young men, the different indicators around housing insecurity for children, young people and families, and the ways in which local authorities are and are not responding to those, and physical activity insecurity for LGBTQ+ children and young people. Secondly, in terms of a healthy start to life, the two projects around poverty-proofing maternity services and exploring food insecurity in pregnancy. And then thirdly, in terms of the third work strand, there's a project that's just about to get going around evaluating the impact of an active school environment for children and young people, which builds on previous similar research. And pending executive approval, a project around the holiday and food club programme. So I want to just, before handing on, to just say a couple of things about our communication and PPIE strategies. Firstly, just a bit of an advert, really. We have a quarterly newsletter, which Kaya has been collating, and we've put a huge amount of work into ways in which we want to communicate the aims of our programme, the work we're doing, and get people involved. If you're not on our mailing list, if you have any interest in children, young people and families from any perspective, please do contact us. Our details are on the SPHR website. And as it says on the slide, that newsletter is open to all with an interest in the programme. We're also aiming to have quarterly programme seminars. We've moved from a phase of designing and co-designing the projects to a phase now where we'd like to talk around some of the key academic questions, methods, ethics, and so on within and across the projects. Those, again, will be open to all, not only to members of the projects. So that includes PhD students, pre-docs, postdocs, public and policymakers with an interest in those specific projects. We really want to make those open fora for discussing the research. And there'll also be ad hoc member leads meetings, which will focus a little more on the kind of business of the projects. Finally, just a big thank you to Dr. Hannah Fairbrother from Sheffield, who is leading the PPIE element of our work. She's working within the programme more broadly with GJ and others to develop a YPAN, a Young People's Advisory Network, across the school. And we've taken the approach generally that within many of the projects there are established PPI mechanisms and relationships. So Hannah's role will be to sort of build on those, bring them together where possible, and look at the interface with the school-wide YPAN. So that's all I'd like to say. I'd like to hand over now to David Taylor-Robinson from Lilac to talk a little more about that cross-programme strand of work. David.
Hi everyone. It's so nice to be back here in Newcastle, and thanks Peter, and to see lots of friends and colleagues. So I'm presenting on behalf of a number of people involved in this data work that started already, particularly colleagues at Imperial, Hannah Crease and Dougal Hargreaves, GJ, who's also in the room today, so a cast of thousands. I want to give you some context and then talk about what we've done in SPHR2 and how some of the analyses that we're going to be doing in SPHR3 build on this work. We wrote a report that was partially funded by the school, the Child of the North report, in which we started with this quote from Nelson Mandela: "There's no keener revelation of a society's soul than the way it treats its children." And if you subscribe to that sentiment, then the situation playing out at the moment for children, particularly for kids here in the northeast of England and places like Liverpool and Newcastle, it paints a really troubling picture of our society, I would argue. If we take a step back and look at how we do on average for kids' health in the UK, the UN have suggested that we're number 27 in OECD rich countries in terms of rankings. If you like football, like I do, that's like Preston in the Championship. Whereas as a nation, no disrespect to Preston, but as a nation, we kind of consider ourselves a Champions League type of country. And it's difficult to achieve those types of aims if we're running at 27 for children's health. And one of the reasons for the shocking levels of poor health in this country is that there are large numbers of children in poverty, almost 40% of kids in poverty here in Newcastle. And those children have particularly poor outcomes, which brings down the average. We showed in the Child of the North report how we went into the pandemic in a bad shape and how the pandemic has increased inequalities, and far from building back better, as we've heard, we've lurched into another economic and social crisis. In that report, we documented stories, everyday stories of hardship. Some of these from the northeast, parents using watered down milk because of the price of formula, kids routinely turning up to school without shoes, people are unable to attend appointments, parents terminating wanted pregnancies because they can't afford the cost of a new baby. So I guess the work that we're doing through the Children and Young People's programme gets to the heart of the intergenerational cycle of health inequalities and how we can break that cycle. So how poor adult social and health disadvantage affects the conditions into which children are born, which affects children's development, their attainment, and then transmits to the next generation. And I guess the central idea here is that we can get to grips with this complex system and the moving parts in this system through putting together the large hadron colliders worth of data and intelligence that we share across the School for Public Health Research in expertise and access to linked individual level data sets, cohorts, new birth cohort studies, etc., across the collaboration. So, harmonising with the areas that Peter outlined, I'm just going to illustrate some analyses that we're going to take forward. So first of all, in the early years, in SPHR2, we looked at infant mortality. The plot here shows rising infant mortality from 2013-14 onwards in the most disadvantaged kids, and we showed how rising child poverty contributed to 600 extra infant deaths in that period. We've got new data now, so we're going to pick up on the child mortality story. This plot here shows the latest data. It shows infant mortality in the most deprived decile and the least deprived decile, and the dotted line shows the absolute inequality in infant mortality. Essentially, we've seen over 10 years of complete stagnation on action on child mortality, when in other countries, in places like Sweden, every year infant mortality reduces. 1.7 in Sweden at the moment, it's 1.2 in Hong Kong. That's smaller than the best, the areas that have the best outcome. And we know that this is driven by the intersection of wicked problems, racism, poverty impacting to affect the conditions in which children are born. So Sheon Ehsan, who's one of our launching fellows, is leading some of this work, looking at children and child and maternal health. In terms of the environment, we need healthy environments for children. We, in SPHR2, Sonia and colleagues and Hannah looked at asthma and showed how disadvantaged children are twice as likely to develop persistent asthma, and that all of the action, 2/3 of that inequality, is generated by differential exposure to risk factors in the first 3 years of life. So picking up on that analysis, we're going to look at that story through a different data lens. So we're going to use CPRD and linked data linked to environmental data, and we're going to understand what would be the impact on inequalities in asthma if we acted on improving treatment pathways for kids with asthma, or if we acted on air quality. So putting bounds around where policy can act to address health inequalities. We know education is a major determinant of health, and again, work led by Imperial is going to look at how, using Millennium Cohort Study, the children are now becoming adults, so we can look at that intergenerational cycle. So we're undertaking an analysis now that looks at kids' transition or not into employment, and we're going to understand how health and mental health impacts transition into employment in the latest birth cohort data that we have access to. We sucked up a lot of data in SPHR2 in the place-based longitudinal data resource. And I guess the thinking behind that was to look at the inputs and outputs to systems that affect health, following the money. So we showed, using that data, that cuts to spending on early years prevention for children increased obesity and increased inequalities in obesity. But what we haven't looked at is spending on schooling, which is an important determinant of health. And we've seen this huge natural experiment. This plot shows funding for schools over time. We saw a period of investment and then disinvestment, 10% disinvestment in schooling, and then an increase subsequent to the latest budget rounds. But what has been the distributional and health inequalities impact of that changing funding? Because over time, we've seen huge differences in inequalities in educational attainment. This just shows data from Millennium showing the north-south divide in educational attainment in children, showing that children in the north are much more likely to fail at education at age 17. Here's a quick look at some of the data. We've been putting together the spending data. This shows spend per pupil plotted against deprivation, IDACI, with a regression line through the data. This is the latest spending data. Each blob is a local authority. And you can see that large disadvantaged areas in the north, such as Newcastle and Liverpool, get much less funding per pupil than large disadvantaged areas in London. And we're going to look at what impact this has had on differences in attainment, which vary around the country. Finally, turning to children's mental health, which we know is a critical issue, and segueing into the next discussion on public mental health. This is data that we generated in SPHR3 showing the rise in probable mental health problems by deprivation. So the rise in absolute levels of mental health problems in kids over the period of the pandemic, and the rise in absolute inequalities. And we're now looking at this issue using linked individual level data at population level in a number of places. So we have access to data through Cypher in Liverpool, in Cheshire and Merseyside, covering 2.6 million people, and also data in northwest London through WISC, through our Imperial colleagues. This is data from Cypher, from Liverpool, hot off the press, showing using routinely linked data through hospital admission records and read codes in GP surgery, showing the rise in the incidence of depression in men and women, particularly in young people, that started before the pandemic, was exacerbated to an extent by the pandemic, and is now continuing. We see the same thing for depression and also for anxiety. So we're going to be using these data to look at inequalities and the drivers of mental health problems across the population. I guess people don't like hearing about poor child health in this country. Some people say it's depressing. I guess I'm more glass half full. There's so much scope for improvement, and we've got the data and expertise as part of the school to make a real impact on policy, so that we can help design better public policy for children. So I'm optimistic that we can make a difference. I'm going to hand over to my colleague Erin from OHID.
Great, thank you so much, David, and thank you very much for the opportunity to talk here. So as David said, I'm here from the Department of Health and Social Care. I'm a researcher working in the Early Years Children and Families team, and today I'm just going to spend about 5 minutes talking to you about the policy landscape in the department. And really what I'd like to do is to leave you with some thoughts about the priorities that we think this means for research, to really build the evidence and try to achieve that kind of population level change in children and young people's health that we're all here for. So I'd like to start just with some reflections on what the main challenges in early years children, young people's and families policy are. And I think as public health professionals, this will be familiar to many of you, but I think it's really worth us articulating that this is the context in which we're trying to make policy at the moment. So the first of these is our desire to build a whole system approach to the health of babies, children and young people. And what we mean by this is that hearing families' voices, we know that services can often feel fragmented. For example, when you have a baby, it's sometimes difficult to know where to go to get support, and it's difficult to understand what is available to you. So this is really bringing families' voices into the way that we think about policy and that we design it, so then that the services that we deliver can do the best benefit for health by feeling cohesive and joined up. And part of that is also making sure that we create services that serve everyone, recognizing that variation across the country and recognizing, as Lorna put it, that there's no average life, that there's a lot of variation that we need to cater for. Within this, though, we do have some challenges. We need to recognize that we want to have a health system that can better cater to the needs of babies, children and young people, but within the reality of current pressures, namely budgetary pressures and workforce pressures. So, for example, this is thinking about policies that can make the use of existing workforce and can think of different ways of working so that we can improve things like, for example, universal health visitor coverage without necessarily being able to increase the workforce associated with that in the short term. Cutting across all of our work, and as we've heard again as a theme today, is reducing health disparities as a priority. We recognize, however, in doing this, that we need to be really realistic about what the bounds of the health system are and what we can do as a department, and where there are also drivers sitting outside the health system and what our role is there. And it's really worth recognizing that in terms of, again, the reality of how we build evidence and how we kind of use that within our policy making. And finally, I think a really cross-cutting challenge, and one of the things I'd really like to leave you with today, is just the challenge of evidencing the impact of policy interventions and also building the economic case for investment. And there's a couple of points I'd like to pull out here. One is that on evidencing the impact of policy interventions, one thing that we've heard that we really have good evidence on a lot of the time are the kind of causal mechanisms driving inequalities, for example, or the causes of why certain poor health outcomes exist. The thing that's actually really challenging and that kind of missing piece is being able to build evidence about what policy implementation we need on the ground and how that should vary and why. And that kind of implementation evidence and making sure we have policy that genuinely works for people is, I think, a really kind of key thing for us to be building evidence around. The other part is building the economic case for investment. And it feels very intuitive to say that we should, of course, be focusing on prevention, and we should, of course, be focusing on prevention research. But there are two main challenges with building the economic case. The first of these is that the costs of that you actually get from prevention tend to actually accrue over time. So they're not necessarily savings that you then make immediately, for example, in acute care. And these aren't things that you'll necessarily be able to see kind of come to you in the next kind of 5 to 10 years. So it's really important to firstly recognize that there can be massive gains from prevention, but this isn't necessarily realized immediately. The second element of this is the fact that benefits are often distributed. And so we know, for example, that if you're investing in, stop smoking support or weight support, you might not necessarily see the benefits of that back to your policy areas. This will be kind of benefits that are distributed throughout the system. So it's really about thinking about how we actually build this case for investment, and we're just really clear about how we kind of build that evidence and build that sort of logical argument about why we should be investing. So with that in mind and with that kind of context, I just wanted to give you a flavour of some of our key policy priorities across the children and young people's life course at the moment. And as you can see, these are really ranging from things that are meant to be quite universal, and particularly in the early years and family space, and then also things that are more about kind of vulnerability as children and young people get older. So we have a focus on stop smoking support in pregnancy, which we know is a key area for intervention. Then when we move up to the pregnancy through to the infancy and early years, one of our key flagship programs at the moment is one called the Start for Life program, where we're really trying to improve universal support to families throughout half the country at the moment, but then with a hope that that will be delivered more widely. We also then further up the life course have a focus on vulnerable babies and children, and that's particularly thinking about safeguarding and what the health system can do for that, as well as better understanding the health of care experienced children and young people. And then across all children and young people, we're also doing a lot of work to try to improve mental health and mental resilience and well-being, and again thinking about that from quite a systemic perspective as well. So I appreciate that's a really quick canter through. I only have a few minutes, but I just wanted to give you a flavour of some of the things that we're thinking about at the moment. So what does this mean then for research priorities? So there are a few things that I'd like to leave you with. So down there in the blue, I've shown sort of some of the cross-cutting themes of our work, and then just some reflections on what we think this could mean for research. So obviously what we're doing and what I've been talking about from kind of my perspective of the part of the organisation is about the importance of prevention for children and young people's health. And what this means for research, as I've said, is we really do need a strong evidence base on the areas of preventions, and as I said, critically, how this can be delivered in practice. And again, it's almost moving that evidence base beyond the problem and beyond an analysis of causality, which again, in many cases, we have good evidence of, but then saying what's the actual policy that can be implemented in practice? How does this vary across the country, and what does that mean for where we should be investing and what we should be supporting? We also then, as I said, have a real priority on providing cohesive services across the health system for families. And one of the key priorities here is actually just to get children, young people's and families' voices into policy making. So to understand how experiences feel for them. And again, recognizing that nobody has an average life. So how do you incorporate that into policies that feel effective in an equal way for everyone across the country? And then for reducing disparities, which as I've said is a cross-cutting part of our work, I think, again, it's worth emphasising the need to be really detailed and focused on what we mean here and disparities for who and at what points in the life course. And within this, making sure we do improve our evidence base on what we can do as a health and care sector to reduce these, and where there are wider drivers and how we think about influencing other parts of the system for that. And then finally, the final point I'd like to leave you with is just about the role of evaluating impact and building that economic case especially. And I think if there's one thing to take away from this, it's really that value of building evidence on implementation and building evidence about how policies work in practice. And of course, we know that evidence of causality and evidence of the problem is really critical because that helps us hone where we should be investing, but ultimately also understanding how policies work in practice and making sure we can sustain that over time is incredibly valuable. And you'll be hearing our Deputy Chief Scientific Advisor, Dr. Mary D. Silva, talking to you later this afternoon about prevention research and research priorities more broadly across the department as well. So I'll leave it there.